Welcome to the third session in the Lunch and Learn series, Gender Affirming Care. We're so glad you're able to make it and join us. Today is Gender Affirming Care and HIV Prevention, and next week will be Insights from Living Expertise, a panel discussion. Just to let you know, this session is being recorded and we will be sharing the slides in a week or two from both of our presenters. Today's session is brought to you by Casey House in partnership with the OHTN, and the wonderful Diana Campbell is here to support with any tech issues. And my name is Thomas Egdorf. I'm the Education Development Coordinator with Casey House. Before we get into the content, let's start in a good way with a land acknowledgement. I join you today from traditional Indigenous lands. As a settler, I recognize that gender-affirming and HIV-related care continues to be shaped by colonial systems that create barriers for Indigenous peoples. This acknowledgement is a reminder to center dignity, safety, and reconciliation in how we support communities. And now let me introduce the speakers. It's my pleasure to introduce Mia Bondi, who is a nurse practitioner and assistant professor at York University with a clinical and academic focus on HIV prevention, hepatitis B and C, and mental health across Ontario. With training in microbiology, immunology, and primary health care, Mia works in both urban street outreach and rural remote communities. Outside of academia, the clinical practice, Mia also volunteers as a primary care nurse practitioner supporting individuals at risk of or experiencing trafficking. And our second speaker today is Kenny Dawkins, who provides inclusive sexual health resources to 2SGBTQ plus communities with a focus on improving access to gender-affirming care for trans, non-binary, and gender-expansive people. Through an annual community engagement committee, Kenny gathers feedback on barriers and experiences navigating health and community services. This insight informs resources such as the Trans Health Card, which supports gender-affirming conversations between clients and providers. And with that, I'll turn it over to Mia.
There we go. Thank you, everyone, for your patience on that. And Thomas, I'll just do a check-in that you can see my slides full screen.
Yep, looks great.
Spectacular. Well, welcome, everyone. Thank you so much for spending time with us today on your lunch hour or wherever you're situated. We're really grateful. And I'm so grateful to be able to share some of our work as it intersects with gender-affirming care and HIV prevention. So I know this is a very experienced group, but I just feel like I would be remiss to not sort of situate ourselves in the 10 years post-HIV prevention rollout in Canada, because there's been a lot of major changes. And as much as our neighbors to the south are doing things that we might not agree with, I will be also referencing multiple CDC documents because unfortunately, they are still ahead of us in a lot of spaces than we are in Canada. So I wanted to give those sort of disclaimers. So there has been a major shift since Health Canada approval. And you might recall that prior to approval, there was really a lack of knowledge among providers, among the public around HIV prevention. But the focus has largely been on PrEP. So specifically taking medication prophylactically, so before exposure. But since the initial rollout and approval, there are now modalities such as on-demand PrEP, PEP as a primary mechanism of HIV prevention, so post-exposure, and then something called post-exposure in pocket, which I'm going to go into a little bit more detail just in case folks aren't super familiar with it. But unfortunately, a lot of the studies still are around very specific populations and communities. So when we talk as clinicians, or with clinicians, I should say, around high quality evidence, unfortunately, a lot of communities are not included, which of course is really limits access and offerings. At least with oral-based HIV prevention, the majority of studies have been amongst very specific communities. And again, this might not be very inclusive amongst folks who use drugs or trans and non-binary populations. And because of that, a lot of the efficacy benchmarks also in guidelines will say things like low quality evidence, which is absolutely problematic in terms of access and offerings. Another big game changer, I would say, though, for Ontario is that non-specialists are increasingly prescribing HIV prevention, which is fantastic. And OHTN has shared a lot of this data, which is really, really important to take it out of specialty centers. But that still, non-specialists may not have adequate knowledge around prescribing HIV prevention and providing care for other communities that are not gay and bisexual men who have sex with men. And then finally, I'm going to talk a lot about new modalities, which will be game changing and I think have been game changing. But just in terms of offering and making sure we're doing exclusively universal offering around all of the options. So just to review, so we'll just quickly zip through some of these modalities in terms of the technology, right? So oral prep, Health Canada approved in 2016. This is our generic TDF FTC that's been available in Canada generically since 2017. 2017 was the year when people really started to be able to access PrEP because no one could afford the brand name of TDF FTC. There's also a second oral combination therapy, TAF FTC, goes by the brand name Descovy, and again is very limited in terms of access because there is no generic. So it's not covered by Ontario Drug Benefit. There is a compassionate program that I'll speak to in a moment, but it's not really widely available for most people. In terms of how PrEP has been used, so one pill once a day, or some of the very early studies that looked at on demand or event driven HIV PrEP, where people take two pills 2 to 24 hours prior to sex, one pill 24 hours after that, and one pill 48 hours after that. And as the evidence continued to accumulate, the guidelines then changed to continue to take medication until it's been a certain number of hours. And you can see the diagram there since the last time someone might have had sex. So really looking at exposure. I won't cover doxypep in this talk, but of course, doxypep is another oral modality around STI prevention that has really been exclusively studied, unfortunately, in a specific community. So as I speak, and please feel free to ask questions in the chat, we're really looking at, what is the balance between evidence and rollout? So do we need all the evidence in terms of offering, or can we have shared decision making with clients, patients, people, whichever terminology we're using, to offer without all of the evidence? Thinking about anatomy and prevention, so thinking about language, what language might be used, and I'm going to actually challenge this very guideline-driven figure up here. So thinking that you need 21 days in order to have vaginal or frontal absorption in order to provide protection with HIV prevention, specifically oral prevention, and only 7 days with anal sex. However, one thing that the CDC has come out with recently is that actually the concentrations that were required were based on having the concentration of drug in the tissue, and that has been shown to not be a good efficacy benchmark. So just to say it in a more plain way, the CDC is recommending that 7 days for all types of tissue is appropriate. The old adage of 21 days in vaginal tissue might not be appropriate. And so really thinking about how we universally offer and counsel. The same is going to be true around STBBI testing. So really thinking about how am I having these conversations to guide the type of testing that makes sense for the person sitting in front of me? So how might you ask those questions? And I think this is more of a reflection exercise and a practice exercise than me telling you how you should ask those questions, because we all have our styles. But asking what type of sex you have, and then how that would guide specifically chlamydia gonorrhea testing, which is site specific. And a lot of folks actually don't know that. Clinicians don't know that. Folks in community might not know that one test is not the same as another test. And there needs to actually be site specific testing, so anatomy site specific testing. Type of sex may also be impacted via early on post surgery. What's required to provide harm reduction? Is it more lubrication? Is it additional testing? Are we looking at taking a break for a little while post surgery? So, thinking about how you're going to work with the population that you're working with to think about all of these things. And then I made the point about PrEP concentration in certain tissues as a major point of discussion. And I will just point out that a lot of the Canadian resources, specifically the BC resource, also still says 21 days. So this is an example of when our neighbors to the south are doing a little bit of a better job in public health messaging than we are. I'll flip to chat about injectable PrEP. So many of you will know that we do have an approved injectable PrEP in Canada. It's been approved for just a very short while. The study was fairly groundbreaking. And the one thing I want to highlight from the study was that the incidence of new infections was just dramatically lower than any other oral based clinical trial. On the heels of this approval of cabotegravir, which is our once every 2 month injectable HIV prevention medication that's a single drug, there has been an FDA approval for a medication called lenacapavir, which is a once every 6 month injectable HIV prevention medication. And as I understand it, this is with Health Canada for approval. And, we're looking at sometime in 2026, as I understand it. But one thing that's happening with both of these medications are some really important real world data gathering, specifically to trans women and various clinical trials that are focused on women or trans women. So you can see there, Purpose 2 is specifically focused on trans women. Purpose 4 is specifically focused on folks who use drugs. And these are the names of the clinical trials. This is one of my favorite figures that the CDC produces because it says out of all of this algorithm, you follow the whole algorithm, and at the end of the day, all roads lead to offer HIV prevention. So if you work your way through the algorithm for sexual health, it's the positivity, it's the partners, it's the blah, blah, blah. And then it's prescribe or offer. And this is something we're not doing well in Canada. We're using risk screening guidelines, and irrespective of the population, we're using risk screening guidelines, we're risk averse. And part of it does come down to the fact that clinicians are not super well versed in antivirals. I mean, there hasn't been a lot of them until COVID. And so, really getting that comfort with antivirals, the way clinicians have comfort with antibiotics, and really thinking about that offer PrEP, offer PrEP, offer PrEP. Discuss PrEP in co-localized settings. Discuss PrEP when people are coming in for prevention around just general health prevention, right? It won't be a surprise to anyone on this call to know that people don't talk about sexual health in primary care. They're uncomfortable for lots of reasons, and primary care is also uncomfortable for lots of reasons. Uncomfortable, limited time, all those things. And so just really being sex positive and open around that offering of PrEP, irrespective of the person's life stage or what assumptions are being made. This is my second favorite figure because it says that for folks who use drugs, all roads lead to offer PrEP. So whether or not they're sharing drug use equipment, whether or not they have that other additional risk around sexual exposure, all roads leads to offer PrEP. And I think early days, again, there's some sort of concern around offering PrEP because of things like adherence and drug resistance and all these things that are teeny, 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 tiny risks in comparison to someone actually acquiring HIV, which is a real risk, right? So there's a lot of hangups, I think, among the public, I think among clinicians, and I think among service workers as well. So getting this knowledge out that like PrEP's not going to necessarily be perfect, no matter the community, and that we need to just offer because it's not our choice. The last thing I'm going to talk about before I switch to talking about trans folks and specific interventions around PrEP is just this idea of PEP in pocket. And so this is a really nice study presented by Isaac Bogosh, who's at UHN from COI 2023, and looking at flexibility, right? So people might actually start their engagement with the healthcare system in the emergency room getting PEP. They could be then transitioned to post-exposure in pocket, which is actually prescribing PEP in advance. So people have it ready. They don't need to go to the emergency room. They don't need to call a healthcare provider. They don't need to get access because most people don't have access to rapid healthcare providers. And then of the 111 people who were prescribed PIP, some people didn't initiate it, some people initiated it, and some people transitioned to PrEP, right? So this flexibility, PEP, PIP, PrEP, PIP, as it makes sense for people. And I know this is very acronym driven, but it's a really important and valuable option for people who, for lots of reasons, might not want to be on daily PrEP, might not want the injectable. It's just a really important option that we make all of these things a menu of options for folks. I'm going to move to talking about drug-drug interactions and hormone therapy. And I know this is a very experienced group, but for some reason, this information still sits high level around concerns that are related to interactions between PrEP and hormone therapy. And I think we're way beyond clinical trials. We have wonderful national and international guidelines that there's absolutely no reason why folks on hormone therapy cannot take PrEP. I'm going to go back to the data and the concerns about the data, right? So when we think about trans folks and transgender women specifically, there are different options than transgender men and non-binary people assigned female at birth versus, again, transgender women and non-binary people assigned male at birth. So how I look at it is evidence is important. It's great, but we should be offering things to people that make sense for them that they would like to do, right? So if we think about transgender women and non-binary people assigned male at birth, we'd be looking at guideline-driven, absolutely offering oral TDF-FTC, oral TAF-FTC, and cabotegravir injections. The same would be true for the population below transgender men and people assigned female at birth, except that there's not necessarily that evidence around Descovy. This was also true of cisgender women for some time until the investment was made in a clinical trial, right? And that's one of the challenges around equity here. The clinical trials don't necessarily exist among the populations where it makes the most sense. And so then we don't have the data. But could you offer Descovy to a transgender man? Shared decision making, right? You talk about that there might not be evidence. We understand tissue concentrations. We don't think the tissue concentrations are going to be different. And or people might be on another medication. That means they can't go on oral TDF-FTC and they don't want an injectable cabotegravir. So then we have to, again, holistically look at, what are the things that they would like to do. I had wanted to cover a little bit around coverage because in Ontario, this is very problematic. I mean, in other provinces, there are central programs that deliver HIV prevention, such as British Columbia and Manitoba. And look, they have their issues as well around eligibility criteria and things that still limit access. But one thing that you might consider as a community provider, as a service provider, is identifying pharmacies that are doing some amount of volume of this to help with the navigation of getting the medication. It's a lot for frontline folks to do this health services navigation. And so partnering with pharmacies or pharmacists who are really expert can be helpful. So TDF-FTC and CAB-LA are on ODB, but obviously Descovy is not. And whether or not lenacapavir gets covered by ODB, we won't know until the time has come. So some of the manufacturers also have compassionate programs, and I've generally found them to be excellent, but they do have criteria and they come with paperwork. So this also speaks to the maybe the desire to work with experienced pharmacists and pharmacies so that we can limit our own paperwork burden and sort of task shift to another individual. You're probably aware that there's also a program called Prep Start in Ontario, which provides folks with 3 free months of TDF-FTC. And then larger pharmacies, not even the manufacturers, may provide some aspect of compassionate prep. That's likely going to be TDF-FTC because it's generic, whereas the others are on brand and they're more expensive. So I was trying to think about the best way to talk about trans folks and HIV prevention because this is a very experienced group. There's lots you'll find in guidelines. I think the messaging is quite clear around hormones. So I wanted to share a little bit of research that we've been doing in this space. So we've done an international scoping review, and then we've looked at the findings by community. So I've titled this theme, access and offerings. So this was a study done in New York City. And one interesting thing, maybe not so surprising, is that folks who are already engaged in gender affirming care had higher access to HIV prevention. There were also suggestions from community, so from trans folks, around the best ways this could be rolled out. And I think we're at the precipice of this in Ontario and Canada with the injectables coming or already here, that we can really think about this and really be strategic. So here are some things that were found. So offering in settings where trans women are already frequenting and where they're comfortable. Offering other services at the location that can holistically address trans women's needs. Utilizing peers to recruit and educate trans women. Having a trans women's focus that includes gender affirming care. Considering same day prep. So that could be same day off of a point of care test. That would be fantastic. And then the need for sex positive, very inclusive advertising. And one thing I didn't include in this, but it's so interesting, is some of the really fascinating like ad campaigns in places like Vietnam and places like Brazil, where they're thinking way different than we think in North America. But because the US and Canada sort of operate similarly around messaging, I thought I'd pull this New York City data. But there are some really fantastic and really cutting edge advertising campaigns happening around the world. Another thing that came from community in this scoping review was really looking around challenging the concept of this word risk, right? So making assumptions that trans folks have a higher risk. This has come out clear from community that this is happening. And community had emphasized the need to look at, and again, I'm quoting, it's behaviors, not identity, highlighting the importance of social and structural circumstances. And, that should really be moved to the top, and my apologies, because that's obviously the most important thing that was found. There are social and structural inequities that shape vulnerability. The groups urged that HIV prevention strategies should be tailored to the realities of trans women. And I must admit, there's less data on trans men. Inappropriate or inaccurate transgender representation in PrEP advertising. You can tell with some of this work that there was no community involvement. Perception that PrEP for cisgender men who have sex with men is sort of the group to target. The need for nuanced, inclusive, and culturally appropriate messaging, and then the emphasis on strategies that include PrEP that really reflect the diversity of the communities we're engaging. So we've taken some of this data and some of our other work, and about a year ago engaged in what we're looking at, which is largely a women's focused models of care project. So really focusing on trans and cis women for HIV prevention in Ontario. And so we've looked at doing 3 different things in terms of our objectives. And I just wanted to share some of the data that we collected through our focus groups, but just very briefly, our objectives were to co-create sustainable frameworks for partnerships, identify multi-level barriers and enablers for trauma and violence-informed HIV prevention and actually treatment, and identify areas for equity-focused implementation. And so this was some of our research team where we did a flexible analysis, and it included community and academics. And I'm going to end by just sharing our findings, which again are just our early findings, because this was a focus group of 1 of 6 to 8 people, as focus groups are, and to say that our work is not done here. This was a Toronto-based focus group. We know that that's not representative, but I do just want to share, to share what we're thinking or what we've heard. So having a caseworker who can help with appointments and medication pickups and this OHIP application aspect. So that's that OHIP, ODB, medication coverage. And the quote is, we don't know what we have access to. Like we need support to health systems navigate. Some amount of reminders for follow-up appointments. Incentives for adherence came up. Trans-friendly, trans-oriented practitioners and healthcare staff. One-stop shop came up in all of our focus groups. Universally, I think in HIV prevention, it's massively important. People don't want to go to different places for different things, and you need to have peer support or folks with lived and living experience to help with that health systems navigation. And then really inclusive programming. So one thing that was said was that trans men may be less engaged and more hidden. And I'll just quote, hidden due to their experiences with their own culture and how they are treated when they get there. Thinking about employment opportunities as models of care. So this is not created by clinicians for community. It's created by community for community, and clinicians are in the background, right? So the opportunity for training, skills, and leadership, and then empowerment. So we need trans roles in leadership was a quote. We need to be able to have our voices heard. There needs to be opportunities for participation in the building of the models of care. And the quote is, we know what our community needs. Some of the ideas around overcoming these barriers included leveraging networks of trans folks, peer-led education and training sessions, and community building activities. I just want to thank the organizers for having me today. And since I presented some research, I do want to just mention that we had wonderful community advisory boards and service provider advisory boards support this work. And it's a really huge research team. And I'll pass it over to my co-presenter, Kenny.
Um, Thank you, Mia. I actually learned so much in your session just now. I do my own research and like I talk to community, but the medical side of things is there's a lot of misinformation that floats around. So thank you for that. Let me just share my screen. All right, just did a little. So hi everyone. My name is Kenny. I use they, and he pronouns. I know I had an introduction, but I work at ACT as the Queer Community Health Systems Coordinator. So my presentation is going to be a lot more from community voices through conversations I've had since I've been working at ACT. There's going to be a lot of things that I'm going to be echoing that Mia has said. So I think that just speaks to almost how, I guess, knowledgeable the community is about like what they need and like how important a lot of conversations like this are. Um, so the first thing I'm going to talk about is just like barriers to access that community has shared with me. Um, the key things here are like the historical harm that trans folks have faced, medical mistrust, racism and intersectionality, and that what impact that has had on prevention access. Um, so just in this slide, I kind of made this mini timeline, not really. There was way more that was here that I've seen, but just examples of how historically trans folks have been harmed um, by by people in power. Um, so like trans people have always kind of existed for centuries. Um, and one of the earliest like recorded instances of like transgender discrimination through violence was like the execution of a Muslim person from North Africa while in Rome in like n- uh, the 1400s for cross-dressing. And of course, those we've changed a lot of that, but there's still a lot of discrimination more so. And as we know in in places like our neighbors, it's kind of a lot of these laws have been trying to be a lot of the things that we've done to progress forward has been kind of being drawn back. Um, so it's just important to remember that we're trying to continue to move forward, and I think having sessions like this Lunch and Learn is really going to help push that forward. Um, so in addition to the historical harm, I think a lot of it has to do with like colonialism and how that has impacted how we generally society views trans and non-binary folks um, on just like a human level. Um, it really imposed laws and violent practices that targeted gender diverse people and um, led many countries to criminalize gender identity and expression, despite the fact that a lot of cultures had like a third gender or another gender option just naturally amongst their communities. Like even example, like many African societies recognized and respected gender diversity. Um, Ancient Egyptians honored androgynous deities. And even in like 16th century, like Yoruba societies, communities didn't really actually enforce a rigid gender binary and often even delayed gender assignment until much later in a child's life. Um, and despite these long-standing cultural histories, like gender diverse people today still face a lot of widespread discrimination. Um, Including things like misgendering, a denial of services, and being pathologized within healthcare systems. So the in addition to that, there's a lot of medical mistrust. So many trans and gender diverse folks associate health systems with trauma through things like conversion practices, forced sterilization, and being treated as like research projects. Um, so I included in this for gender diverse folks also intersex folks who have more of a an impact on things like sterilization, but it's not limited to just them. Often, a lot of times, intersex folks who don't have a very like black and white identifier of like whatever genitals they have, they're kind of subjected to surgeries. Um, while they're still very, very young, and so that really sets them up for a lot of like not only just confusion, but just a lot of like healthcare concerns later in life because they've been um, because they just how the hormones in their body work, like it'll be different than what the rigid system that like health systems have like brought to uh, specifically like sex assigned at birth. Um, so um, in cosmetic and other like non-medical necessary surgeries, like I mentioned, um, are performed on the physical sex characteristics of intersex children simply because they're born with variations that are not considered to be ideal under like a colonialist perspective of male or female. Um, and unfortunately, some intersex people may also be required to meet sterilization requirements if they wish to change their sex or gender details on official documents in certain countries. Um, and so thankfully, I mean, in June of 2013, the Parliament Assembly of Council of Europe passed like these resolutions um, uh, about to revise laws and policies to ensure that no one can really be coerced into sterilization um, for without kind of like that consent piece. And so the resolution itself also specifically lists trans people as dis disproportionately affected by cohesive sterilization. Um, so in addition to that, we also have things like um, conversion therapy, which there has been a lot more focus when it comes to like sexual identity. But there is also, I think, more subtle conversion practices that kind of happen for trans folks who are looking to transition, whether that's medically or just socially. In fact, there was a whole story behind CAMH, which I won't go into too much detail, but in 2015, they had closed their gender identity clinic for children and youth. Um, and it wasn't very necessarily very clear, but from what community has says, what academics and scholars have said, is that they have been accused and rightfully so about engaging in conversion practices um, for trans folks, which mostly stemmed around it convincing folks that they might not be trans and they might just need a little bit more comfortability around their gender assigned at birth. I also even have experience with CAMH in that specific clinic too. This was like I think it was the in 2013 or so. Um, and I think even for myself, it was a very hard and intense way to just be able to have the coverage that I needed to proceed with surgically transitioning. Um, yeah. Additionally, I just have a direct quote here from Community, who talked about a time when they were looking for care for a stomach problem that they've had for a while. And their healthcare provider was very focused on it being an issue from them taking like oral HRT. Um, and so instead of looking at any other possibilities or even running tests or anything, any sort of blood work. They were really adamant about um, it being related to HRT and how uh, up all of their stomach problems would stop if they were to stop taking it. And I think that really just speaks to the uncomfortableness that some healthcare providers have around HRT and just gender affirming care in general. So, in addition, there is an added addition of like racism and intersectionality when it comes to trans and non-binary folks getting the support that they need. Um, so I'm mostly going to be quoting from the Human Rights Campaign report that was released in 2024. Now, this does come specifically from the US, so it is limited just to that space. But I think it still kind of echoes across the North American healthcare system. And so they since 2013, um, the Human Rights Campaign like recorded the death of 314 trans and gender diverse people. 84% of the victims were people of color. 83% were trans women, and 61% were specifically Black trans women. Um, and so even in this, I have a link to the report here in the slides, so you'll be able to see it if you'd like to in more detail. Um, but even just reading the report itself, it's very clear that Black trans women are particularly disproportionately affected by this epidemic of violence against trans people. Um, and I think in general, it's compounded the mistrust in any sort of like systemic in any system um, with the addition of like transphobia. So the impact on prevention, there folks have a lot of fears from what I've heard and what they've shared with me. And they also just have a lot of like avoidance in general around this. So one of the things that they mentioned was the fear of being rejected. So like there's a risk of feeling like they'll have to be outed. when they're trying to receive care, or um, even when they're trying to receive care in general health, or like specifically their sexual health. There's a focus of care that's restricted to potential like gender affirming health treatment causes. So like I mentioned before about uh, the healthcare professional that was very focused that the stomach pain was related to the HRT. Um, there's also like a lack of shared collective knowledge around care for gender diverse folks. I think there's a lot of focus on medical transitioning and like surgical transitioning that I think sometimes some healthcare professionals might forget, like they just also have general health concerns that's not necessarily related to um, transitioning purposes. There's also a lot of mental health challenges that they've shared, daily gender dysphoria and body dysmorphia challenges. So some folks have expressed how they sometimes don't even feel like leaving the house because they're so uncomfortable in their own bodies, or uh, sometimes some folks don't feel like they look enough like the gender that they want to be seen as, and so that stops them from um, doing things like going to appointments or seeking care beyond anything relation to their gender um, journey. Um, so concurrent mental health challenges like anxiety and depression, personality disorders, etc., like compound the avoidance of seeking that care too. And then in addition to that, a lot of folks shared their um, housing, food, and financial insecurities. So then their actual health becomes less a priority because they're still trying to find like basic needs. Like a lot of folks uh, are either unhoused, or they are couch surfing, or they just don't have that same home security that some other folks do, that's what their priority is. The same with food, and the same with having even the finances to go to these appointments, or to do anything other than if they're working. So that becomes another barrier to um, why they don't feel able to access these things. And then lastly, Mia mentioned this earlier, but like a lot of the promotion around PrEP is geared for cisgender gay men. I would even say, unfortunately, I mean, ACT has been doing better, but like a lot of our work is centered around like cisgender gay men. And so even when I reach out to communities personally, they feel a little bit reluctant because of even the messaging that ACT kind of pushes forward. Um, there's misinformation around who can access PrEP. They're unsure of how PrEP actually affects hormones, like Mia had mentioned in her presentation. Um, and so the promotions, again, for this, for accessing PrEP ends up only really targeting a certain group, and then there's a lack of interest because they feel like it isn't actually relevant to them. So I don't have I don't have the medical parts about this. But generally, um, just a bit of a summary. Like hormone therapy and PrEP, as mentioned before, there's no like clinically significant drug interactions between them. Um, there's perceived interaction fears. Like some folks have shared with me that they're worried that somehow taking PrEP will reduce how much their body actually absorbs their gender affirming hormone therapy, and that in itself is just a reason for them to not even look into it. Um, and I think that's unfortunately something that's kind of echoed within community, and community often looks to community for like the answers rather than medical professionals, because they already have a lot of mistrust in healthcare systems, which is completely understandable. Um, and then again, access barriers around information about PrEP's maximum effectiveness is inconsistent between healthcare providers, and honestly, even in some uh, promotional materials, that it kind of leads to avoidable risks and potentially more harm to gender diverse communities. So a bit about PrEP adherence and retention issues that community has shared with me. It's very similar to, I think, generally anyone who's looking for HIV prevention medication, um, with a little bit more specifics. So there's like a fear of being shamed as promiscuous or assumed to be HIV positive for taking PrEP, due to misinformed community members and just general society. Um, there's a fear of assumptions about being irresponsible or immoral, especially since PrEP can reduce the need for condoms for some folks who choose not to use condom or don't want to use condoms during sex. Um, that's not necessarily something we recommend, but we also would never tell other folks how they should be having the sex that they want. Internalizing a lot of the stigma can lead to self-shame and anxiety about their own health, their own gender identity and sexuality. Um, some healthcare providers may hold stigmatizing views, which can really discourage people from seeking care. As I mentioned before, like a lack of consistent housing, gender affirming providers, and healthcare coverage or even access can really disrupt the follow-up care that folks need. So a lot of them have expressed going once, or to one of the services provided and then not feeling comfortable or safe enough to like return to that same spot. And so it ends up with them either just never going back or they have to restart this process again, which is already taxing, um, and also causes a lot of uncertainty. Um, and then daily routine challenges. So I kind of mentioned this before, but mental health, dysphoria, dysmorphia, or even medication fatigue can really reduce adherence. Many folks who are medically transitioning feel overwhelmed, especially if they're folks who are have to actually take daily procedures, or daily medications. Okay. Daily medications, it just really tires them out. And then most prep programs are designed around, again, around cisgender gay men's health. So they don't really feel like it connects with them. So, and in addition, community priorities, they don't really feel like it's a priority. They really talk about like other priorities, like finding their next meal, that is more important. The lack of accessible messaging. Um, so they aren't, this is a quote from one of the community members I've spoken to. Um, they just rather not take that risk if they're not sure if they're going to be taken care of properly. Um, and then the perceived relevance, like I mentioned, they feel like if the messaging isn't right, then they don't feel like something like PrEP is for them, and they don't really actually have to be concerned about it. Um, so I think I'm running a little bit uh, over my time. So I think I will just go a little bit ahead. This slideshow will be available to folks, so that's okay. But I think most importantly, supporting ASO workers in kind of providing this gender affirming care and access to preventative services is training all staff, new and old, normalize using your own pronouns when you're introducing yourself, collaborating with other trans and gender diverse-led organizations, using trans and gender diverse folks in promotions, also hiring them both as peer and staff, and providing education programs not only for your staff members, but also for other service users, if you're starting to include more trans people or trans programming into your spaces. and then provide peer-reviewed and trusted resources. All right, so I think that's it for me right now. Um, I This slideshow will be available after. So if you have any questions, just please let me know. Let me stop sharing.
Well, thank you, Mia and Kenny. I found your talks really great. Some of it was new information, some of it was a reminder, and definitely food for thought. So we do have a bit of time if anyone wants to put that you can either type in a question in the Q&A, or you can raise your hand using the raise hand function. Just note if you do raise your hand, you will be part of the recording. So not everyone is comfortable with doing that. The Q&A is a little bit more anonymous.
There is a question in the chat there, Thomas.
Great, thank you. Let me get down to that. For Kenny, is there a resource you like to point people who want to deepen their learning and capacity for working with trans folks? For example, Katie comes to mind for me for HIV.
Yeah, I think my usual, unfortunately, there's not uh, like a service like Katie, which is just like kind of like a website that has like all the information out there. I sometimes use a website called Trans Folks, which is a lot more community kind of grassroots driven. If you're looking for something a little bit more, I guess, professional, I would suggest the Rainbow Health Ontario. Um, I also provide such trainings and conversations within my own work too. Um, it's more about just being able to find folks who are interested in having those conversations. So I think there's a few options that you have there.
Great, thank you. Would you be able to put the website in the Trans Folks website in the chat under everyone? That would be great.
Absolutely.
And from Philip, not a question, but some info. There are two trans-oriented sexual health booklets out there, Primed for trans masculine and Brazen for trans feminine. I find them very useful. And I'll just add to that, I think you can find those on the Katie website, but I'm not 100% sure. And a follow-up for Mia, do you think people who use drugs should be using PrEP? For example, is HIV transmission occurring through sharing drug equipment?
Thanks so much for the question. And maybe I can also use it to like follow up on some of the other questions that I answered in the chat. Because I really want to center this discussion on not guidelines, but shared decision making. So, for example, one question in the chat was about like on-demand prep, and of course, the language from multiple organizations is on-demand prep has not been studied among trans folks, right? That does not necessarily mean that that's not an option that we should offer. So, I guess to the question around folks who use drugs, it's that maybe taking away the language of the should, like should people use it, and rather saying like should we be offering it, right? So should we be offering it? I mean, I hope my algorithm from CDC 2021 was very clear that we should be offering it to everyone. Yes, it's possible that folks are being exposed to HIV through use of shared drug use equipment, but regardless, this is like, I mean, technologically speaking, this is an amazing modality to be able to offer people, for people to take their health into their own hands. So it's really about the offering. And then I might just add that if you think about this changing landscape, we don't know if folks who use drugs will want injectable medications, right? I mean, that's really not well studied. It could be a really good modality because it's long, like 6 months, to only have to have an injection every 6 months and be protected. But we really don't know if that's what community wants.
And we have two more comments. Oh, and I see Mia is already answering those.
No, go ahead. I think speaking to them, like for you to speak to them, is really important just so everyone hears it.
Great. And then that's probably all we'll have the time for. I would like to highlight the urgent need to include two-spirited people in these conversations, and please allow us to learn from two-spirit experts as well. There's a lack of data regarding HIV prevalence among two-spirited people. However, we know that ongoing settler colonialism is a massive factor in their displacement. So I don't know if that either of you wanted to comment on that. And then lastly, shared decision making is a new framing for me. Are there trainings about this framing or similar framings that you would recommend? It seems very broadly useful.
Yeah, it's definitely a concept, and Kenny jump in too, but it's definitely a concept that's sort of across like many clinical areas. Maybe I could put a slide in my deck that gets sent out that's specifically around shared decision making as a follow-up. Thanks for that
That would
question.
be great. And the last question, oral sex HIV transmission chances, question mark.
Kenny, did you want to, or do you want me to, or?
Um, I feel like you'd probably know a little bit more, but from what I know, I think transmission is very dependent on a lot of factors. I think the, for example, the chances of getting HIV transmission from oral is less unless there's like some sort of like blood interaction or like open sore interaction. But was there another was there another one that they asked about? Ooh, I can't see it anymore. So I think it ultimately it really depends. One, if the person that you're um having sex with has HIV, and two, it depends on if there's any sort of way for that transmission to happen by some sort of abrasion or like mucus lining.
Yeah, I usually use the expression the risk approaches zero. It's just an extremely low risk. It's never no risk, but it approaches zero.
Yeah.
Okay, and that's all the time we have this week. Again, Mia, Kenny, thank you so much for your time and sharing your expertise with all of us. And thank you all who attended today. We change the world with information one moment at a time. So thank you. Next week, we have our panel discussion and hope that you can all make it for that. And
Thank
I
you.
also want to thank Diana Campbell, my wonderful partner. And yeah, that's it. Have a great rest of your Thursday.